When you are well, you belong to yourself. When you are sick, you belong to your family. Hi everyone, my name is Dr. Ntizimira. I'm the author of the Safari Concepts and the Executive Director of Acreol Global. I'm a palliative care physician. I'm also expert in global health and social medicine. I was really interested on a kind of anthropology, try to understand about the people and about the culture before to bring palliative care concepts in Rwandan culture. As you said, I'm an author of the Safari Concept. I married one wife and I have 3 boys. Yeah, that is I think what I can say about myself, but I'm really interested about mostly what's related to palliative care, about meeting people and understanding about the social culture perspective mostly. After medical school, my dream was to be a surgeon because I thought that becoming a surgeon would be the best way I can help to rebuilding the health system and so to contribute. Until I met a very young guy, 24 years old, who was really dying in pain. He was diagnosed with hepatocellular carcinoma, which is commonly people say liver cancer, and it was advanced stage. I was really familiar with physical pain because I was working in surgery department in Kibagabaga Hospital, but his pain was totally different with the common pain, physical pain I used to treat because his pain was mixed with suffering. And unfortunately, I couldn't handle, his situation because that time I feared to prescribe morphine, which is a strong opioid mostly using for people with severe pain. And the sad story, his mom came to me and kneeled before me and asked if I can do something which can help a son to sleep and wake up no more. She's kind of actually asking for death, and I was very shocked because I find that proposition or that suggestion very out of kind of my scope of work. Using and prescribing morphine, of course, I was really feared and say if I prescribe morphine and the patient die, and then that will be my fault. So I was really scared to even to prescribe about that. So then I questioned myself what the reason to become a physician if my role just to witness people who are dying in pain. So what the reason to become a physician? So it's in that context, then I was trying to find out why there is something miss in our training, especially. And I didn't know about palliative care. I mean the terminology palliative care itself, and unfortunately I felt that I failed twice. I failed as a physician because I couldn't prescribe morphine, even if morphine was available in the hospital. But also I failed as a Rwandan because when you see elder person kneels before a young person, culturally that means you are fair. So then I starting to rethink about what's the really meaning to be a physician. And in that context, the Minister of Health organized, I think it was the first palliative care training, and I was selected by the hospital to attend 10 days of training of palliative care. And during the training, I was expecting to hear more about the suffering of the patients and the families, and unfortunately, it was about my own suffering. So sometimes, our own ignorance may affect the perception of care of the patient and family members. So I've learned from there, and I decided to move from my dream to become a surgeon for a new passion, palliative care. I think we need to go back first to the history of palliative care in Rwanda. In 2011, Rwanda became the first African country to launch it was a standalone policy on palliative care. and the implementation plan, and for I think 4 and 5 years, so which made Rwanda the first African country to get access to have a policy for palliative care, and also access to morphine, and also training for healthcare professionals. From there, if we compare to other African countries, I think there is a very big step have been done by the government of Rwanda to make palliative care not a reality, but also implemented in the country in terms of education, because there is a lot of training have been happened since 2011. And also access to morphine. Now morphine is available. It's a morphine syrup, which is free of charge for all patients. And also recently the University of Rwanda now developed a curriculum of palliative care, which is really integrated. So I think I'm not seeing that what are the barriers. I think now I'm thinking about what is more opportunities Rwanda has to become not only a leader in palliative care in Africa, but also a leader on the way palliative care should be integrated in the Rwanda public health system, or using a national public health system to become more inspiring for other health systems to see how palliative care will be integrated, how will be connected to the communities, and also to the perception, because the perception could be totally different from one setting to another. So I think what we need to strengthen now is education, not only training, but education, because we have a new generation, we have a new people we need to understand. And as you mentioned, when you mention about palliative care, people think about death. Yeah, which is, I mean, it's the whole concept itself needs to be redefined, and I think that's on my sense something we need to continue to work on with the Ministry of Health and the RBC, and to change the perception of palliative care, that palliative care is not about death, it's about life until the end. Dignity, humanity, and compassion. From my ethnography research, I've learned from Rwanda culture that when you are well, you belong to yourself, but when you are sick, you belong to your family in terms of decision making. And it was really important to understand that patient autonomy need to go with community responsibility. So it's both. It's not only focused on patient autonomy, but we need also to bring the community responsibility. It's about the intersection between both for a very good decision making. And also, part of the book, I tried to explain two different concepts. Treating the disease and treating the person are two different concepts, because you can treat the disease without treating the person. But if you treat the person, you have 100% chance to treat also the disease as well. So this is why I was clarifying in the book from my experiences from Kibagabaga and working also at the community, that is really important to we need to focus by treating the person. That is the most important thing. We need to treat the person. And when we say we treat the person, one, understanding the perception of care of the person and also the families, understanding the environment and the ecosystem of the patients, because that's also really important. Try to define or redefine how the death and dying, based on the social culture perspective, and also what will be the solution, especially us as the physicians, and not only physicians, but also the healthcare professionals, to understand our role. And our role is not just to prescribe, but also our role also is to reconcile. Sometimes we need to reconcile patients and families, reconcile patient with his own disease, because sometimes people deny that they have, for example, cancer or HIV. And also to reconcile also families with the disease, because sometimes family is asking how this happened. This person has been healthy from the last 10 years. Well, why cancer now? And also we have also this component I like a lot in palliative care. It's about spirituality. So, and this has to be it's something really important when I'm discussing with people that spirituality and religion are two different concepts. Because religion is part of spirituality, but spirituality is not religion. And every patient is spiritual, but every patient is not religious. So this is how some of the components we need to understand more than a medical trajectory, but understanding about the social culture perspective. And this is how the book came out. It was just sharing experiences and also help a new generation, which is really explained in the book. I want new physician to avoid some of the mistake I did, like the story of the young guy, and also some of the mistake, about my own fear. Sometimes you can bring your own fear on the discussion, and that also may impact on the care of the patient. And also to learn that palliative care, even if it's not a sexy specialty, but it could be something people can talk about. And with the community, including patient and the families as well. And our role is to reconcile on that on that way, I can say. I think we don't need to reinvent the wheel. There is already existing and successful program we have here in Rwanda, like HIV, tuberculosis, malaria. We just need to use the same, approach, the same vibes and the same momentum, and experiences. And part of that with the Ministry of Health and the RBC, some of the training we've done with the RBC was to train, hospitals and go down to the health centers and also go down to the community and train community health workers. And that is something really important, because when you mention about compassion, it's not only at the hospital level. Compassion has to be, compassion has been in Africa part of our culture. We've been compassionate on different ways. Check when, during the weddings, you see weddings in Rwanda, funeral in Rwanda, how many people attend. And we don't necessarily need a card, invitation card, to attend some of the social events. Mostly people, when they know you, they say, oh, I know this person, I will attend about either funeral, weddings, or any social events. So we need to use that part of our culture, which is, I think, is the most important thing we can use. It's human resources to be able to engage and re-engage when vulnerability, came up on the society, and when someone feel lonely, and to see how the community can be able to support that. And this is, for me, compassion will be something, one of the greater things, Africa may teach, out of the continent, about something is part of our culture and something people can use. And instead, we don't need to recreate that, because we already use it in our community, and there is so many successful experiences. I think we need, one, it's advocacy. I love one of my friends used to say, it's if you are not part of, if you don't have a seat on the table, you are part of the menu, and probably you are the main course. So advocacy is something really important. I totally understand, based on the misconception, myth, it's happened everywhere. People may say, oh, palliative care is just for this group of people. And in Rwanda, no. Access to treatment for any type of program is available to anyone, from the community to the hospital. This is why I'm using mostly the experiences of Rwanda to say, access, universal health coverage in Rwanda, it's a very tangible, and we have indicators for that. And we need to be, instead of to copy and paste some of the model which is not aligned with our perception, just to use what we have. And we have so many examples. So it's not a luxury, because one, it's integrated in Rwanda public health system. Second, it's very accessible. As I said, palliative care, it's accessible and available, because something can be available but not accessible. And which the patient, may pay, I think 10%, and the rest is paid by the government. And also we have the community engagement on that. So at this level, it's not a luxury. Luxury could be when there is a disparity in the system, where only rich people can get access and poor don't have access. But in our sense, if you see other programs, like, as I said, HIV and tuberculosis, everyone have access for that. From the corner of north, south of the country, people have access to any kind of treatment. So we're using the same system, the same successful, approach to integrate also palliative care on that way. So then we will reduce the disparity between rich and poor, or between urban and rural, but everyone who needs palliative care will get access to palliative care. But it's an unfortunate, but some side of the world, you can see people only get access to palliative care if you get enough financial resources, I mean. So we need to first to deconstruct palliative care, because most of the model we have in Africa came from different clinical and culture experiences, mostly from Europe and America. And because palliative care is not only focused on physical, but also spiritual, psychological, and social, we need to make sure that the society understands about what is palliative care. As I said, it's not about copy and paste. So, the experiences we have in Rwanda, and part of the exercise we had, I remember last time with working with the RBC, was to see, to understand what is the translation of palliative care in Kenya, Rwanda. Starting from there, starting to understand what is the translation, how people have their own perception, what is the spirituality background about death and dying. So, in that context, it will be easy for policymaker one to adapt about the policies. So the policy will be adapted and will be focused on the local understanding. Second, we need also to increase about data and research, because we need to do more and more research and bring evidence-based about palliative care itself, about who needs palliative care. And I mean, in our context, is it only cancer patient or other conditions? What is the gender disparity on access to palliative care? That's also one of the questions. And also pediatric palliative care, for under 15, what type of model we need to develop for pediatric palliative care. We have so many questions to respond, and evidence-based will contribute to the policy and bring a policy which could be really adapted to the context, instead of just, some places, when people want just you to take their policies and just implement it, which cannot really work in our context. My approach will be in 3D approach. One is to democratize palliative care. It's a complex topic, but we need to use simple words. Second will be to destigmatize palliative care. We need to remove all misconceptions and myths beyond the concept itself. And the last D is to deconstruct. We need a local model of palliative care. Because I'm teaching now at the University of Rwanda, and all the time when I'm sharing my experiences with medical students, I always say that the way a patient dies may reflect how the society lives. So you need to think about it when you treat a patient, because the way that patient will die will reflect how our society lives. So that is, my vision is really focused on the 3D approach: democratize, destigmatize, and also to deconstruct. I'll finish with one story. When I was doing my fellowship in palliative care in Boston, and shadowing my mentor in palliative care, Dr. Eric Rakau, we went to visiting patients in palliative care wards. And it was my first time, many years ago, traveling in the US. So I didn't know anything about US culture, American culture. So I went to the hospital, and we found some patients. Most of the patients were alone, but surrounded with pictures, on the bed, and there were so many pictures, photos, and the patient was part of the photos, but very happy, surrounding by so many people. So the first day I couldn't ask because I was like, okay, I can ask. Maybe there is a reason. We go to the second patient. It was the same. So after 1 week, I asked my mentor, why there so many photos in the room of the patient? And he said, because the family are not here. And they say, why? So he explained to me, Christian, this is what we call East Coast, and family live in West Coast. And I was very naive that time, and I asked again, is any flight from East to West Coast? And he said, yes, there are so many flights, JetBlue, Delta, and blah, blah, blah. And I said, why the family cannot travel from West to East? Because he was so tired with my questions and say, what about in Rwanda? I say, in Rwanda, we don't have photos in the room because we have people. And then I told him, maybe you need also to learn from us how to replace all those pictures with human being. And for me, this is my vision, is to have more human being when someone is on the last mile of his life. And that will become an accomplishment for everyone.